It's Zach Winkleman. I'm here presenting for attr 810 for the Integrative Care class for the lower extremity. This is part of my PhD in curriculum and instruction with the athletic training concentration. As part of that, I take classes in the Doctorate of Athletic Training. This week we were tasked with kind of exploring clinical prediction rules, specifically in the lower extremity, and kind of hyper-focused at the ankle and the lower extremity at the lower leg. So what I plan to do today is kind of explain my clinical decision making when it comes to the ankle, some things that I do well, some things that I can improve on, and some areas that I would like to target to focus on as I move forward as an expert clinician. So first is my current injury evaluation reflection. As a clinician, I think that the ankle is probably the strongest area in terms of a body region that I clinically perform. I feel confident with my clinical decision making and clinical expertise within the special test to make a sound decision for either return to play, referral, or treatment considerations. So typically what this would look like for a patient that's reporting off field into the clinic, I would begin by taking a history. What I typically do during that history is start to palpate during that, so I'm talking to them and palpating at the same time. Some people would argue that this is not good clinical practice just because of the not focusing on what they're actually saying. But I kind of like to integrate both into that, especially in an athletic training clinic with the time constraints. This helps me kind of integrate subjective and objective assessment together while listening to the patient about different things. In addition to my current reflection, I believe that once I finish a thorough history, that also incorporates history of ankle sprains and how many and how often they've had them. I always ask the question as well if they were braced or taped, and if they do, how often they do that. Have they done that since their last injury? I think that's really important based off the literature that we are always, if they have a history of ankle sprain, that we're making sure that that's something that they understand from a treatment and an injury prevention aspect. And then in terms of a injury evaluation itself, making sure that we collect that data in terms of were they taped or braced, and if that was not effective, maybe exploring another taping or bracing option. In terms of going into the objective assessment, my palpation skills, I typically start at the upper leg, so I start usually about tibial tuberosity and work my way down to the ankle. And then once I get towards the syndesmosis joint, I switch and go to the toes and work up the midfoot up into the talar curl and subtalar joints. So typically I start that way and kind of merge together. That way I can gain the patient's trust and confidence during the palpation process. Next, I would typically go into some joint testing and soft tissue testing. Typically begin with anterior drawer and posterior drawer. If I'm getting laxity with some of those, I'm trying to elicit some comments or information back from the patient in terms of what that would mean from them in terms of what they are having issues with. I know that special testing is not always the first rule of thumb in terms of the assessment process. I like to do anterior and posterior drawer before I go into doing range of motion, just to kind of see where they're at in terms of laxity if they're presenting into the clinic that way. After I do anterior posterior drawer, I typically then would do active and passive and resistive range of motion. Typically, I do not do inversion range of motion when they're presenting with a lateral pain over lateral malleolus or ATF, CF, and PTF fibers. There's no sense in me putting them in that position to test them in any of the directions personally, because that's how the mechanism of injury was, typically from the patient history, and I don't think that's something that is important to put them back into after that injury has already occurred. I do assess through the entire plane. When I do my range of motion, I have my patients lie prone, and I measure with the goniometer lying prone in the clinic. When I'm doing this on the field, I typically don't use a goniometer. I also do functional testing with them for range of motion, so going up on their toes, going back on their heels, seeing if they're able to do those things as well. After that, I typically will go back into some special testing if necessary and do Taylor tilt tests and Kleigers. Those are if some of the palpation and special testing that I've already done in range of motion are eliciting maybe a syndesmosis sprain. I may go into some of those additional testings. If not, I may have the patient do some balance exams, so have them stand on one foot, see if they can come up on their toes, maybe jump or hop, depending on the severity of the ankle sprain. If it's a grade 1, if I'm assuming it's a grade 1 at this point, and leaning towards that, so minimal laxity, minimal pain, maybe reduced swelling, I will have them do some functional tests. I think I bring up a good point with swelling then too. Swelling, I typically do kind of a sweep test or just a visual observation. I think this is something that I can improve on in terms of how to quantify swelling. So I think that's something to really pick up on. And then the visual observation, obviously, is something that I do at the beginning of this whole process. So just looking for deformities, ecchymosis, edema, seeing if it's localized to the joint or if there's areas that it's swelling up the calf or down into the foot. I typically also explore other joints and making sure they don't have any blood clots or things that are forming at other places. So in terms of my subjective assessment, I believe that I'm asking good questions. I don't believe I'm getting all the questions that I need about the patient. I think what I'm doing is getting the questions for the injury. I think I do this because I want to find out why they are hurting or what's causing them. So typically the mechanism, and that's the main reason why, is I need to find out which way their ankle rolled or how they thought someone landed down on their foot. And I think that kind of guides me in terms of my clinical decision making through the funnel of the possible injuries. After that, I get into pain assessments, typically use a visual analog scale or numeric rating scale for those. And so kind of asking them where they're at on that pain, where they were last night, previous treatments that have occurred. And the subjective assessment is literally just to listen to the patient. But I really, really dive into past history for ankle sprains. My objective assessment, as I said, I really focus on anterior posterior drawer and then go into Taylor tilt and Kleigers. Other than that, I typically don't use many other special tests for the ankle. I feel like those have really good sensitivity and specificity, and in terms of palpation paired with those, I think that limits the amount of time that I need to be testing them or doing different things. In addition to that, I will use Ottawa ankle rules if necessary. I typically combine it into a process that I wouldn't necessarily call it the Ottawa ankle rules. And so if they present by walking into my clinic, I observe their gait. And then if while palpating they have pain on that distal 1/3 of their malleolus of the fibula, those are things that I could pair together to say maybe this is something that you would need an x-ray for. I just typically don't present them together in my mind as Ottawa ankle rules. And when documenting, this is something that I really have a deficit in. So my clinical decision making is really based on the aspect of osteoarthritis and chronic ankle instability when I'm going through ankle sprains. Lateral ankle sprains to me are one of those things that kind of get pushed off to the side, and it's something that I don't want to make patients unaware of the risk of playing with an ankle sprain. So I think that's something that I really push through my evaluation so they know that, yes, we need to put in the time for this. Yes, I probably could push right on the ATF, elicit pain, do some testing for range of motion, and be able to tell you that you have an ankle sprain and we're going to need to tape you and maybe take a few days off while we return to play. But I really want to take the time to actually go through a thorough evaluation and make sure that the patient understands that this is just as important as an ACL tear. So my clinical decision making kind of guides through there. My improvement areas are integrating patient-reported outcomes. This is something I would like to do through a history and subjective process. Data-driven clinical exams, so integrating things like volumetry or girth measurements for swelling. Delayed diagnostic exam from the readings this week and from the NATA position statement on conservative management. Doing the diagnostic exam after 4 to 5 days is best practice, and this is something I really want to start to integrate into my clinical practice. The issue is that patients typically don't come back 4 to 5 days after a grade 1 ankle sprain because they're probably already returned to play. So that's something I would like to focus on. The patient-centered interview, actually taking time and focusing on them as a person, listening to their deficits in terms of their life and not just sport, and stop using the term, it's just an ankle sprain. I think that's something I really want to work on. So as a whole, I think I want to really improve my clinical practice through integration of those 5 goals. and reflecting on that as we move forward. So when I set my goals correctly, they'll take me in the right direction, and that's how I believe that my clinical expertise can occur moving forward. Thanks.